Yes, yes.
Yes. Welcome all for today's e-Gurukul Pathshala and today's OSCE by expert session. We have our expert with us, Dr. Baldev Prajapati sir. So for today's session, I invite Dr. Jhankhana Sanghavi madam for this AOPG Presidential Action Plan of e-Gurukul Pathshala welcome address. Madam.
Thank you, Nehal. Good evening everyone and welcome everyone. I welcome respected Prajapati Shah, Dr. Yogesh, Parikh, Dr. Sandeep Prajapati, Dr. Nehal Patel, Dr. Lata, every seniors and all delegates. OSCE is not only for the exam purpose. I think OSCE help everyone, even pediatrician also. OSCE initiate our thinking process in scientifically as well as logically. And today's OSCE is by the expert, very respected Prajapati sir. Let's enrich our skill with the Prajapati sir with his OSCE. Thank you.
Thank you so much, madam. So, with this brief OSCE introduction by madam, I invite Dr. Yogesh Parikh sir, who envisioned these different types of learning methods in this e-Gurukul Pathshala for his blessings. Yogesh Parikh sir.
Thank you, madam. Thank you. And let me congratulate and thanks Dr. Prajapati sir, Dr. Jhankhana madam, and Nehal madam, and all. Today this is the week, third week of the March 2021. We have started this e-Gurukul program on the online, and this is the 5th year completed. So I congratulate the team AOP Gujarat led by Dr. Jhankhana Sanghavi madam for this wonderful initiative and with the starting this program again with the presidential action plan. So thank you very much, and let us, without wasting the time, we can start the program here. Over to you, madam.
Thank you, Yogesh sir, and not wasting much time, handing over to Lata and sir for the very best OSCE program.
Good evening, everyone. I'll not take a minute also. So, sir, please start the program as we are already very late.
Okay, should I start?
Yes, sir.
Am I audible?
Yes, sir.
Lata,
Yes,
am I?
Yes, sir. Yes, sir.
Okay. Thank you. Good evening, friends. Some technical issues are beyond our control, but still I think we will continue in even odd circumstances also our learning. Just I will take 1 minute. Almost probably 25 years back in LG, that was our scheduled teaching. And there was a forecast of very heavy rain in Ahmedabad. I was on the way and I received a phone call from one of my residents that, sir, it is very heavily clouded and forecast that there is going to be the very heavy rain in the city of Ahmedabad. What we will do regarding our teaching? I said even with the heavy rain, suppose by chance even the water enters the LG hospital, will continue this our teaching session, will not drop in. So Lata, what I want to convey, that whatever the circumstances develop, we'll try to overcome, but we'll continue to learning. Anyway, this is a very important message. That's why I said we will manage the circumstances, but it happens sometimes beyond our control. This time also, somehow I could not manage to open my presentation. Dr. Lata will control the presentation as my request. So I think please you can go forward. Lata, next slide.
It's not moving somehow.
I hope that it should move.
Is it moving, sir?
Not moving, or at least on my screen.
Sir. Okay, so let me try, sir, again. That time it was moving now.
At least not moving on my screen.
Let me see.
If it happens, so I think you can stop sharing and then restart. So
Sir,
problem will
sir, if you have joined by the laptop, then you can share.
Sorry?
Sir, if you have joined by the laptop, then you can also share.
No, I am not able to share. That's why I requested her. I
Yes,
tried
yes,
for
yes.
about 45 minutes.
It's same happening. So it's not moving. Slides are not moving. So let me try again. Let me try again.
I think best way you can stop sharing and then
Yeah,
restart it.
that's what I
Probably
will do.
because already it has opened up on your laptop, so it should move.
Yes, sir, that I will.
Yes, now it is there. You can make it full screen.
Now it is moving. Yes.
Yeah, now moving. So let us go further. This is, yes, very good. So let us come. I will say still we are late, but we'll complete whatever we have planned and still will be able to manage. A 6 years old boy is finding difficulty in getting up as shown in the pictures below. Just go to the next. Already, I hope that picture is seen. What is the name of this sign? Lata, I think you can check
Yes, sir.
the,
Yes, sir.
yes,
Chat box, I'll check, sir.
how many responses are there. So let
Yes,
us see.
sir.
It's a goer sign. Next click.
Yes.
Because question then answer. So you'll have to go for multiple clicks.
Yes, sir. Goa sign. Everybody has answered. Goa sign.
Yeah. I think you can click the answer. Next.
Okay.
So that we can save the time because I think goer sign everybody knows. Right. Second question. At what age this sign is fully expressed? And at what age it may be evident? That means at what time it will be partially present and at what age you are expecting. The reason is, if you suspect.
Yes, sir. So 2 people have answered.
Yes.
6, 3 to 4, 3 years.
Anyway, I think you can click the answer. Lata, you can click the answer.
Yes. I'm doing that, sir. You know what is happening when I'm doing this.
Yes, multiple answers are there.
Yes.
3 to 5 years.
Yes.
3
5
years.
3 years. Yeah.
5 years it will be completely present. All the, I will say, features shown in the pictures. But at the 3 years may not be classical. Just child is taking some support or difficulty in finding getting up. May not be all the features. But as a clinician, if you observe, from 3 years even, sometimes you may be able to suspect that, yes, it is the goer sign. Yes, next question. And then what deficiency is responsible for disease? I think the disease is clear. So I don't go for the naming the disease. But what basic defect is there, which is responsible for the? Yes, diagnosis DMD, yes. But I want the basic defect. What is the basic problem with this DMD? Somebody has put very nicely dystrophin. Many people. So Lata, I think to save the time, we can click the answer that dystrophin is a skeletal system in the cell, which is a deficit and responsible for their early muscle destruction and results in this myopathy. Okay, next. Next question. Which clinical syndrome in girls? It is an X-linked disorder basically. So it will be present in the males only, not in girls. But in very specific syndrome, girls have been found with the full clinical picture of this disease. Very good. Dr. Jazz, Turner syndrome. Limb girdle, no. Limb girdle is quite different. Lionization, yes, that is another condition. But please, this happens in the OSCE. Lionization is not correct answer. Yes, it can happen. But here the question is, which very specific syndrome in the girl? So answer is only Turner syndrome. Yes, some other conditions, lionization, Turner, even some other situations, it may develop. So in OSCE, all of us know that answer is very precise. Maybe the multiple, I will say, resembling answers, but one of them will be the most correct. Next, please. Question is at what age usually they die? And what are the common causes for death in this group? You know, when we are talking to the parents regarding the prognosis and everything, we have to talk. Yes, Dr. Kirti has put 10 to 12, Dr. Deepa has put 18. So various answers. Somebody has put infections for the responsible for the cause. But I'm sure that answer will give you the surprise. Somebody said yes, cardiomyopathy, cardiac. So I think, Lata, now you can put your answer. Yes, age is usually second decade, 18 to 20 years. And most common reason for the respiratory failure, or even yes, following the cardiomyopathy, intractable cardiac failure, and even airway obstruction may be resolved. So these are the three most common causes responsible for death in the DMD. That is Duchenne variety of pseudohypertrophic muscular dystrophy. Okay, go to the next question. Please attentively listen and look at the picture. An 8-year-old boy presented with illness of 18 months duration in the form of headache and vomiting. And they are gradually increasing, progressive, difficulty in vision and no fever. He was proportionate short and fundus examination showed papilledema. And this is his picture of the CT brain. Just I will say few seconds, you can concentrate for the CT brain, and then I will, please wait for the answer. Dr. Asha, very good. I will appreciate your promptness. Go to the next question. I will say next picture. What is the question? Somebody has put yes. What is your diagnosis? Answer is you are already there in the click only, craniopharyngioma. Some people have put the answer. Next question, Dr. Lata. What are the CT findings? You know, people will not be asked the diagnosis. Examiner wants to ask in a different way. Then what are your CT brain findings? What that means, what the picture shows. Somebody has put ventriculomegaly, somebody has put calcification. Yes. Yes, calcification is multiple, but anything else beyond that? Somebody has put mass, yes. Empty cella, please, not empty cella. On the contrary, cella has created the problem. But let us see the answer.
The click.
Lata, yes. You know, that is a cystic swelling. From the appearance of the whitish color, it indicates the presence of fluid. Therefore, we can say the cystic fluid, cystic swelling. Yes, calcification, many people appreciated, and that is in supracellular area, that means pituitary area, which even the development of hydrocephalus. So for correct answer, craniopharyngioma, everything is not correct answer. CT findings, cystic swelling, calcification, anatomical location in the supracellular area, and there is hydrocephalus. So this will be the correct. Next question. What embryonal structure is responsible for this disorder? Anatomy. Yes, Rathke's pouch, very good. Dr. Rohit, Rathke's pouch. So Lata, without waiting, we can click the answer. And everybody is right, Rathke's pouch. Next question. What endocrinal disorders are known to occur in this disease? Sometimes, you know, this disease does not present as the mass or there is intracranial pressure, but present as some endocrinal disorder. On investigations, you may come to know that yes, the cause is something else. I think in the presence of endocrinologist, Dr. Jhalak, we are discussing that what endocrinal disorders are known to occur. Growth hormone deficiency, somebody has put yes. Some other. Panhypopituitarism, Dr. Shruti has put. Okay. I hope that if I mentioning the name to appreciate, they don't mind, even if the wrong answer. But my purpose is to appreciate the person that at least they are putting their opinion on the chat box. Okay, Lata, I think you can click the answer. Yes, hypopituitarism may be the common, that's why the short stature. Sometimes it presents precocious puberty even, and occasionally diabetes insipidus. Presentation in diabetes insipidus may not be raised intraocular pressure or mass presentation. Just on investigations, you will come to know that yes, basic problem is craniopharyngioma related, of course, due to the pituitary. So, we understand that just by knowing, you are not able to attempt OSCE. You'll have to very precise answers. An answer should be addressed to the question, not whatever you are knowing. That is the difference in OSCE and other exams. Every exam paper, you can write down whatever you are knowing on craniopharyngioma, and everything is right. Here, everything is not right. Here, right answer addressed to the question is considered as the correct answer. So, repeatedly, I want to draw the attention of the students because it is very common mistake to observe in the DNB exams. Okay, Lata, you can go to the next question. Next picture. Yes. A 9-year-old boy presented with, and these pictures are of real patients, which I have seen in the practice, presented with easy fatigability and diplopia. And second picture was taken after the administration of some drug IV dude. Dr. Rohit, thank you very much for your prompt response, but the question is something different. Now, Lata, you can go to the question. Of course, name the condition. Many people have answered myasthenia gravis, so without taking much time, you can click. What is the site of lesion in this nervous system? Where is the problem? Somebody has put yes in the short. Synapse may not be the correct answer. NMG, I understand now it is the era of the short form. So neuromuscular junction problem. Very good. Dr. Shivani has put neuromuscular junction, and Lata, you can click the answer. And answer is neuromuscular junction. Go to the next question. And which drug is administered for clinical testing? And what is the diagnostic dose of this drug? So you'll have to name the, yes, Dr. Jayas is very prompt and correct answer. Adrophonium. What is the dose of the adrophonium? I really appreciate many students are present and they are answering very promptly. Lata, I think you can click the answer. It is adrophonium chloride by trade name Tensilon. It is available. Dose is 0.1 to 0.2 milligram per kg. I hope that once you see the patient and you treat it, dramatically within few minutes, child is able to open the eyes and able to walk. Anyway, next question. And next question is, yes, maximum dose is 10 milligram. Which drug should be available? Should be kept, I will say, available in a syringe loaded for IV administration at the bedside during this clinical test. That is very important. And what is its dose? Dose of the particular drug. Which drug should be kept ready? Pyridostigmine is the, I will say, sister of the adrophonia. So not the same drug, something else. Not the neostigmine. And that's why I will say it happens mistake in the exam. Something else, if I give some clue, that side effect of this drug is possible. And to overcome this side effect of the drug, somebody has now started to answer correctly, and correct answer is atropine, not even the adrenaline. So I think, yes, she has put the answer on the chat box. Yes, here also atropine sulfate. Dose is 0.01 milligram per kg. And what is the, why we keep the atropine ready? Sometimes there may be the muscarinic effects of the adrophonia. And there may be the fever, perspiration, tachycardia. And to overcome this problem, atropine should be ready. So just to give us some illustrations that what question they can format for keeping the picture of myasthenia gravis or something else. At the same time, I think what our president was mentioning is right, that this is one of the ways of discussion. It will be useful even in the practice. Even in theory paper also, you can answer all these questions. Yes, Dr. Lata, can you go to the next question? Yes, look at the picture. This is for the spot. And therefore, I have not kept even any comment or any information regarding this. Yes, Dr. Kirti somebody has put so many things. Let me go to the question. So, name the clinical eye sign. Yes, somebody has, many students, many people even, may not be all the students, some of the practitioners, they have put the sun setting sign. Yes, answer. Lata, you can click the
Yes, sir.
answer.
Yes, sir.
Setting sun eye sign. Next question. The question is, what is the mechanism of this sign? In the hydrocephalus, why this type of the sign develops? Which mechanism is playing the role? Yes, pressure in the tectum, third cranial nerve. Third cranial nerve is not the correct answer, not the sixth nerve palsy. But somebody has put the very first response was correct. Let me explain in details. Lata, you can click the answer. You know what happens that in the hydrocephalus, there is a dilatation of the suprapineal recess. And the dilated suprapineal recess causes the impingement, that is the pressure, compression over the tectum of the part of the brain. What is the tectum? Another name is the quadrigeminal plate, which is responsible for the upward gaze. So there is a paralysis of the upward gaze due to the compression effect over the tectum, and it happens due to the dilated suprapineal recess. I'm sure that if you explain in the examiner will be impressed. And to impress the examiner, you should go with some good preparations. Next question, Dr. Lata. Name the sign elicitable on percussion of skull in this condition beyond the age of 2 years. Yes, crackpot. What is the name of the scientist? Name of the sign, yes, Messeval sign, very good. Many responses are there. You can put the answer, Dr. Lata. Yes, Messeval sign or crackpot, but I have put the answer 2 to 18 years of age. In the Viva, I may ask the question, why the 2 to 18 years? Why the 2 to 18 years age is selected for the crackpot sign or Messeval sign due to the hydrocephalus, or even sometimes there is any intracranial pressure condition. Please remember over here that before 2 years, switch AF is open. So switchers are open. So otherwise also the crackpot sign is going to be there. So no importance. So importance is after 2 years. But why the 18 years? After 18 years also there is no, this sign cannot be elicitable. Even in a case of hydrocephalus, adults. Reason is, after the 2 years, the sutures are closed, but there is a membranous closure. They are closed, but with a raised intracranial pressure, they are openable. And therefore, a crackpot sign develops. But after the age of 18 years, there is the osseous closure, bony closure. And therefore, after the 18 years, once it is closed by the bone, it is not able. And therefore, the Messeval sign, crackpot sign, in a case of hydrocephalus, it will be present between 2 to 18 years. Below 2 years, sutures are open. After 18 years, it is closed by the bone or the osseous closure has taken place. I'm sure that very few books has written this type of the explanation. Okay, next question. Which regular follow-up examination often indicates this condition at the earliest? This is the, I will say, era which I'm talking before availability for the facility for hydrocephalus and radio imaging. Very good. I'm really happy that even the students of this era, they know, but I think in the practice they should do. Sometimes you are good in answering the question, but somehow not following in the practice. And that is the serial head circumference measurement. After the discharge of the newborn, due to some problem of meningitis, birth asphyxia, on follow-up of the baby, always measure the head circumference, occipitofrontal circumference, plot on the growth chart, so that you know exactly whether it is disproportionately enlarging or not. So this is very important, most practical question. And Lata, you can go to the next question. Next, yes, photograph. This is a book picture which I have taken because it was not with my patient. There was a history of decreased movements of this baby in utero. And this infant also had, you can look at the picture, that what is the appearance of the baby. Yes, very good. Some, I will say, exam going students are there. Many of them are there, and I think they have the good preparation. Go to the question. Dr. Lata, yes, what is your diagnosis? Many students have answered, SMA. So click the answer. That is the spinal muscular atrophy. Now there are the types also, varieties. So we'll have to answer very precisely. And that is type 1. Some people, even the name from the person is the Werding-Hoffmann disease. Next question. Next question, which structure of nervous system is affected in this disorder? VMN, upper motor, ANC, that is, I hope that anterior horn cell, motor neuron. I am just speaking out the responses, then you can compare the correct answer when the Dr. Lata clicks. Lower motor. I think it's a time to click the answer, Lata, to inform it is an anterior horn cell. Please remember. Among the peripheral nervous system, the important clue is the fasciculation. Tongue fasciculation always favors anterior horn cell disease. And there is the always important clue for every condition. Suppose neuromuscular junction, easy fatigability and diplopia is a characteristic. Or the anterior horn cell, suppose even GBS, polio, Werding-Hoffmann, these are cell disorders. Gloves and stocking type of peripheral neuropathy is a characteristic of even the peripheral neuritis or the neuropathy. Myopathy, particularly the proximal muscles, is a very characteristic. So what actually I wanted to draw your attention, that remember the question may be some other even in the exam, but this characteristic, if you are knowing, you can answer. Go to the next question. What test can be performed to confirm the diagnosis? Which test should be performed? Which will confirm your clinical possibility? Yes, genetic testing. I think this era everybody will answer. Genetic testing. Yes, MLP, SMN gene. Whole genome sequencing somebody has put. Yes, Dr. Lata, can you click the answer? It was very simple. It's the electromyography and muscle biopsy. Of course, I think genetic testing is not the wrong. It's final answer. Next question. What happens to the CPK in this patient? Because muscle disorders, people are going to ask you, what happens or how is the CPK affected? Yes, raised, increase, 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 and therefore targeted question. My question is targeted. That these are going to be the responses, and response is not right. But now the people have changed their mind. Last few response, the CPK remains normal in this disorder. So please remember, sometimes, they are asking the question twisted because the knee-jerk response that any muscle problem, CPK is going to be raised, but not here. So this is another way which I want to draw your attention, that before responding, read the question appropriately. In OSCE, it is very important. Read the question twice. I'm sure that you are getting sufficient time. There will be the 20 OSCE, and for each OSCE, you are getting the 5 minutes. And examiners are also guided how to frame the question and how much time is to be given. So I think you are going to get the sufficient time. Okay, next. Look at the picture. A 10-year-old boy, born of non-consanguineous parents, with here somebody said 4 minutes, he has 4 minutes. With the normal birth and developmental history, presented with complaints of painless progressive bilateral vision loss, more on the left than on the right since 1 month. But he had the history of recurrent episodes of transient ischemic attacks and seizures 5 years back. His MRI of brain on the left side and MR angio on the right side is given. Look at the picture first. Then the questions will be there. What are the findings of MRI brain and MR angio? Both the pictures, what are your findings? Moya disease, okay, but you have to describe what is the MRI brain is suggesting. Just I think you can click the answer. MRI brain shows the subacute infarct in the left occipital region. Left occipital region, that whitish area which you are able to appreciate, is infarcted area. MR angio shows complete occlusion of right supraclinoid internal carotid, severe narrowing of the left supraclinoid internal carotid, both the sides. Usually it is going to be the both sides, then and then the collaterals will be there. And that shows, next, yes, you can say, moya. What is called the appearance of such MR angio, but how the name is derived. You can go to the answer, Dr. Lata. That is the moya disease. It is progressive cerebrovascular disease caused by the blocked arteries at the base of the brain. And moya name is derived from the Japanese language, meaning thereby the puff of smoke. And it is used to describe the angled appearance of tiny vessels compensating for the blockage. So that's the whole understanding. Can you go to the next question? What are the common causes of this disorder? That is moya. What are the common reasons? Yes, somebody has put tuberous sclerosis. Sickle, very good. Sickle can cause it, right? There are some multiple conditions. Vasculopathy, the very broad terminology. Takayushi will not cause the moya. Takayushi is something different. It's a vasculitis of large vessels. And therefore it will present with it is called as the pulseless disease. And it is called the hypertension in the lower limbs. Sorry, upper limbs. And lower limbs will be having the even the low blood pressure. Okay, Down syndrome and so. Let us see. Dr. Lata will click the answer. Moya, please remember, many times you don't get the cause, and that is idiopathic or primary. Secondary, sickle cell, yes, somebody put the answer. Neurofibromatosis, yes. Trisomy 21, somebody put the down. William, Ehlers syndrome, hyperthyroidism. Please try to remember some of the names. Even in the Viva, people are going to ask you. This type of the X-rays, they will keep in the exam, and then Viva will be conducted. Okay, go to the next condition. Look at the picture. Next, then the question, identify the condition. I think very common condition. If you get it, I think it is easy OSCE in the exam. Every time, not necessarily difficult OSCEs will be there. Sometimes very simple. Okay, can you, yes, meningomyelocele, can you go to the next question? What congenital anomalies of central nervous system are called neurologic defects? Neurologic defects may be the full question in even the theory paper. And nowadays, very important, neurologic defects. I think let us go to the answer because I have tried to put it in a different way. Yes, please remember, this is not just, I will say, for the exam, but for your learning also. Some embryological defects results in the neurologic defects. Defect in the neural folding and formation results in meningomyelocele or anencephaly. Similarly, Disorder post neuronal development results in encephalosis. Incomplete disjunction will result in dermal sinus, dermoid, and epidermal tumors. And premature disjunction, that was the incomplete, but premature will result in spinal cord lipomas. And disorders of the gastrulation will result in spinal cord malformation and neuronic cyst. Similarly, even the thickened film terminali, myelocystosis, any of the sacral agenesis, all are the neural tube defects. Another full question may be the spinal dysraphism. So please remember even the very important question, and even the nowadays we are able to reach the diagnosis with MRI and other, and even the conditions we are able to manage. Then you can see closed spinal dysrhythmia or open. Meningomyelocele and myelocele, they are the examples of open spinal dysraphism. Closed spinal dysraphism, if it is with a subcutaneous mass, they are the lipoma or meningocele. Without subcutaneous mass, which can be complete dysphalic states like disorders of notochord formation, canal agenesis, segmental spinal dysgenesis, and simple dystrophic states will be the examples of fibroma, even the dermal sinus, persistent terminal ventricle, and disorders of midline notochord problems are in the form of the diastomatomelia, neuronic cyst, dorsal enteric fistula. I think not uncommon all these conditions. And nowadays it is very important for every pediatrician to know. Therefore, this can be the full question. Even I'm suggesting some full questions also to the students to prepare. Probably you may get it. And there may be some, I will say, examiners also. So they may also get some idea for drafting the next paper, that it can be in the form of the neural tube defects, spinal cord dysraphism. Next question, please. But you know, sometimes the question will be, what factors are considered responsible for neural tube defects? Next answer, in the form of, yes, Lata, answer, right? Genetical predisposition, mostly it is multifactorial. Environmental, in the form of the maternal diabetes, even B12 status, even pesticides nowadays considered. Yes, all of us know folic acid is very important, and some of the teratogens like anti-epileptic drugs, particularly the valproic and carbamazepine. Next question. Next question is very important. What investigations are useful for antenatal diagnosis? To save the time, Lata, you can click the answer. Yes, antenatal diagnosis, all of us know. We do go for the maternal serum alpha fetoprotein, which is going to be raised. But somebody is going to ask you, in which condition maternal serum alpha fetoprotein will be decreased? You know, Down syndrome. Then ultrasound you can do, amniotic fluid you can do. And investigations after birth, you know, X-ray sample, USG, CT, MRI. Yes, you can go for karyotyping, and renal scan is very important. Okay, next question, just to save the time so that we can give the maximum, I will say, OSCEs. You know, this is going to be a very important question. Even in the Viva, any examiner is going to ask you, what are the indications, doses, duration of folic acid supplementation for primary and secondary prevention of neural tube defects? And even how will you do the family counseling? So, yes, I'm getting the answer on the chat box, 4 milligram, 400 macrogram, 1 month prior to conception to 3 months after, okay? That is from iPhone, which iPhone I don't know, right? So I think Lata can click the answer. Please remember this answer. Remember, very precise answer. Prevention is very important neurologic defects. And that is for periconceptional folic acid supplementation. All prospective mothers, dose is 0.4 milligram or 40 microgram per day. That should start from 2 months prior to conception to 3 months after the conception. That is the duration. And prospective mother with previous child with a neurologic defect. Suppose already she has one child with neurologic defect. She should get folic acid dose is 4 milligram per day. Duration is same, 2 months before the conception and 3 months after the pregnancy or the conception. Please remember the family counseling that if you are knowing the incidence, you can say that suppose the recurrence risk is 4% after one affected child. But suppose unfortunately 2 affected children, that recurrence risk is 10%. And prenatal screening is very, very important. And it requires even termination of pregnancy. So these are the points for family counseling, which we'll have to discuss with that couple. I think very important topic, and they can ask in any form, either the OSCE, either this short, I will say, question in the theory, or even in the discussion in CNS case, or even any type of fiber. Can you go to the next, please? Look at this scenario. A 10-year-old girl presented with episodic headache for past 1 year. Frequency of episode is 3 to 4 in 9 months, lasting for 20 minutes to 1 hour. The headache is associated with photophobia, phonophobia, nausea, and occasionally vomiting. Each episode is relieved with rest, and her mother also has similar problem. So I'm sure that many people have put the answer, but the question may not be so simple. Answer is yes. Dr. Lata, you can put it. It is a migraine. But the next question, what test is used for objective assessment of severity of the headache in children? This is going to be the condition is, yes, very good. I will appreciate 2-3 students. PEDMIDAS, you know that scoring system is there. And you should be aware. Just I wanted to draw your attention. Therefore, I purposefully asked the question. And nowadays, people are going to ask you that PED is for the pediatric MIDAS test. Please, can you answer it? Yes, now. So please, score I have not put here just to save the time. But I want your attention that you should know the score. Next question. What is the treatment of an episode of headache in this disorder? Suppose immediately a patient has come, what should be done? Very good. Somebody has put paracetamol. Somebody has put non-steroidal anti-inflammatory, NSAID, analgesic. Yes, answer is, Dr. Lata, lifestyle modification and analgesic like paracetamol. Next question. What investigations would you like to do for confirmation of the condition? Very good. Next question. Answer, no investigation, and somebody has put really Nehal and it's a clinical diagnosis. Good. Don't go for the CT MRI, what I wanted to say. That is very routinely people are doing. I think with this type of the classical story, unnecessary, we should not go for radiation or waste of your the time. Yes, Dr. Deepa has put history and clinical examination. Very good. Even on examination, you are not going to get anything. Mainly the history. Yes, next question. What is the long-term management? Long-term management is the one is the pharmacotherapy. People have used even the propranolol, 2 to 3 milligram per kg per day. Flunarizine is very specific drug for this migraine. Some people assume the cyproheptadine. Somebody may ask the question, which anti-epileptic drugs are used as for the migraine? And they are the sodium valproate, topiramate, gabapentin, and even levetiracetam. These are used. Not I will say, naproxen, some people are what mentioned, that is in the practice on behalf of, I will say it is replaced by the paracetamol. Paracetamol is a good one. Please remember here what we'll have to explain. And here somebody may ask, what is the counseling? To avoid the exertion, lack of sleep and hunger. Even the bright light, loud noise may precipitate, maybe trigger it. Even nuts, Chinese food, or any trigger suppose already is known, that is to be avoided. This is very important. You know, migraine is now not uncommon. Therefore, it is very important that everybody should know regarding the details of migraine. Even in the pediatric practice, adolescent age group, girls particularly, very commonly we get it. Okay, Lata, what is the next question? A 12 years old obese girl was referred for intermittent headache for 8 months. Again, it is headache. And answer is also headache. Question is going to be headache, if you are not clear. Obese, an episode of headache was also associated with blurring of vision and vomiting. But here now, there is no photophobia, no phonophobia. No history of headache in the family. But fundus examination showed bilateral papilloma. That becomes very important clue. MRI brain was reported as normal. Yes, but I will appreciate that the answers are already there. So, Dr. Lata, you can click because they have mentioned. It is a pseudotumor cerebri. Now you know the terminology change. Remember, it is the idiopathic intracranial hypertension. Old terminology, what we are using, pseudotumor, benign, yes. Next question. But how do you confirm the diagnosis? MRI is not going to help you. Very good. I think somebody is putting from the iPhone. Can you name yourself so that I can identify you and even I can appreciate you? Very good. CSF manometry. Good answer. So click the answer. CSF manometry or to measure the CSF opening pressure, which routinely we don't do. But I think in such patients we should do. Next question. How will you treat this condition? How will you treat it? Yes, vitamin. Which vitamin? On the contrary, vitamin may create the problem. Reduce the weight, okay. I think reduce the weight is treatment of many conditions. Right. Acetazolamide is the good answer. Very good. Anything else besides medicine? Very simple. Okay, so Dr. Lata, yes, very good. Answer is there, lumbar puncture. You know, therapeutic lumbar puncture. If you are sure, you can remove the CSF. And of course, many people mention, many students mention acetazolamide. Next question. Which drugs are known to cause this disorder? That we should know, I think, being pediatrician. Yes, vitamin A, not vitamin A, hypervitaminosis. Vitamin A toxic, yes. Anything else? Growth hormone. Why we should go for the growth hormone? Hypervitaminosis, yes. Dr. Lata, can you click the answer? Tetracycline. Now we are not using, fortunately, but you know, sometimes people are using. Nalidixic acid, again, not in the use. We have used several times, particularly for dysentery and UTI. Steroids can cause it. Lithium, you know, lithium psychiatry and psychiatrists they are using, very common lithium. So any psychiatric reference, if you get it with this type of presentation, check whether the patient is on lithium or not. Next question. Again, a 6-year-old girl presented with a swaying while walking from 3 years of age. She has unsteady gait and problem is gradually increasing. That means a progressive disease. She also had history of frequent lower respiratory tract infections. Eye examination revealed an important clue. Then what is the diagnosis? Yes, somebody has put Wilson, but some correct answers are appearing on the chat box. I will appreciate. And what is the question, Dr. Lata? Diagnosis, can you click the answer? Click answer is ataxia telangiectasia. Next question. What is the likely eye examination finding which become the important clue? What you will get in the eye examination? No response, yes? Retinitis pigmentosa, no. Telangiectasia, yes. Dilated blood vessels, that is simple description. Can you click the answer, Lata? That is telangiectasia and bulbar conjunctiva. Let me confess over here, this patient was seen in the LG hospital. We were not knowing. For lower respiratory, we sent for the genetic testing. We got the answer report as ataxia telangiectasia. Then I called the patient back and checked the eye. And the patient, there was this telangiectasia. Somehow we missed it because it was not apparent the same. Next question. What is the mode of inheritance of this disease? Yes, answer is autosomal recessive. And next question. Okay, a 5-year-old boy was referred for failure to thrive, anemia, unsteady gait, and progressive swelling. Again, ataxia. The child also had loose stools, bulky, sticky, and oily. Fantastic. I will appreciate the responses. Very good. Dr. Ram Ashish and Jez and Deepa and so many good diagnosis already they have mentioned. Lata, so you'll have to click it and answer is A beta lipoproteinemia. But the question is, what is the characteristic finding on blood peripheral examination? Very good. Somebody has put it. What do you mean by the acanthocytes? Yes, answer is acanthocytes. But what do you mean by? You know, there is an irregular cell margin on the wall of the RBC. Somebody will ask you that why there is irregular margin of cell wall. So there is a lack of very specific protein over the cell wall. And next question, what biochemical test gives an important clue towards the diagnosis of this condition? What you will get in some biochemical test. And actually I diagnosed this patient almost 20 years back with this. Yes?
Ask a question.
To get it. Somebody has put the correct answer. Very good. Yes, Lata, you can click the answer. You know, lipid profile, if you go, cholesterol and triglycerides are significantly low. That is a very characteristic. Next question. What ophthalmological findings may be found in this disorder? Which will become again very important. What do you mean by the RP? Somebody just retinitis pigmentosa, I think, I understand. And correct answer, yes, Dr. Lata is retinitis pigmentosa. Next question, I hope that there should be one more question. Yes. What anatomical part of the CNS is involved in this condition which is responsible for the neurological manifestation? One is mentioned is cerebellum, but you know, beyond that, Something else than the cerebellum? I can't say cerebellum is the wrong answer, but partly answer. Optic nerve, no. Basal ganglia, no. Anything else? You know, if I remind you or give some important clue, that here the main problem is swaying, ataxia. But now the answer has come. What is posterior column? Can you click the answer, Lata? Posterior column of the spinal cord and spinocerebellar tract. Directly not the cerebellum. It's a spinocerebellar tract. It happens due to what? I think I have not put the question, but if I ask you that why the neurological involvement it happens in this condition, and if you supplement something, even good response can be seen. So what very specific? Yes, very good. It is due to the deficiency of vitamin E, which is fat soluble, not B12. Please, no B12. It is very classically vitamin E deficiency, which causes the involvement of posterior column and spinocerebellar tracts and responsible for the all neurological manifestations. And that is the A-beta lipoproteinemia. Acanthocytes, low cholesterol, low triglycerides are very characteristic of this condition. Next, please. Okay, what is the treatment? I think, yes, I was not sure whether I have prepared this question, but you know, treatment is vitamin E. So that is the question. Very good. Can you go to the next question, please? Again, look at the picture and see the scenario. Here is a 11 years old boy presented with frequent falls, unsteady gait, and intentional tremor, gradually progressive over 8 months. On CNS examination, he had pyramidal signs, but deep tendon reflexes were sluggish. It is against the pyramidal tract signs. Bilateral plantar extensors. Echo study of heart revealed cardiomyopathy. And this was his foot deformity. Question is, identify the foot deformity. Dr. Yadagi, I think my question is, yes, very good. It is federated ataxia, but what is the foot deformity? Can you click answer, Lata? Yes. Please remember, it's a pace cavus. This is the beauty of this OSCE. Unless you write the pace cavus and hammer toe, you don't get the marks. So please answer precisely. What is the next question? Already you have answered the diagnosis, and that is the Friedreich's ataxia. Next question. What is the mode of inheritance of this condition? Mode of inheritance, okay, X-linked recessive. Lata, can you click the answer? Please. Many answers were X-linked recessive. You can see it is autosomal recessive. Next. What endocrinal disorder should be screened in this disease? Commonly associated. And therefore, even on follow-up, you should be careful to check it. And that is, yes, very good. Diabetes mellitus, at least some responses are there. Good. Next question. Okay. What is the most common cause of death in this disorder? Don't say diabetes. Okay. HOCM, cardiomyopathy, respiratory failure, and answer will be clicked by madam. That is hypertrophic cardiomyopathy and leading to congestive heart failure. Good. Next question. A 12 years old adolescent girl presented with involuntary, jerky, dance-like movements of limbs. And these are absent during the stay. She also had emotional lability. Okay, answers are already there on the box. What is the probable diagnosis? Answer are there. So Lata, you can click the answer. It's a synonym. Please don't say only chorea, because chorea can happen in many conditions. So you'll have to answer very precisely. It's a synonym chorea, very classically adolescent, girl, and even the very classical picture. Next question. What is the characteristic triad of this condition? What is the triad? That means three important symptoms or signs from which you can say that this is synonym chorea. Yes, emotional, not liability, it's a liability. Okay, next. But okay. Milk will greed, carditis. Carditis will not be there. Okay. So various manifestations, but very specific triad should be there. Not at sleep. Okay. So Lata, can you click the yes? Chorea is very important. Hypotonia and emotional lability. So these are the three things. Next question. What other signs would you like to elicit? Already answer is also there. I think with the click answer is also there. Hypotonia, pronator sign, milk-maid grip, jack in the box tongue movement, hung up ankle jerk, halted speech, and changing handwriting. Changing handwriting is very important. Even somebody may ask in the Bible, what are the conditions where changing handwriting will help you? The changing handwriting is one of the features. On the contrary, from the school, there may be remark from the teacher, or even parents will note it. Very good, some answer is good. Wilson, yes, basal ganglia involvement, hepatic encephalopathy, yes, even the Parkinsonism. In Parkinsonism, what happens? There is a macro letters, what we say, or micrographia, what we say. It's a graph. So micrographia, very good. Somebody has put it. Next question. What investigation should be performed in this patient? Suppose clinically, if you have diagnosed synonym chorea, antibodies, which antibodies? Okay, not okay, ASO titer, ECG. You want to confirm post-streptococcal, may not be available in many patients, but you should. So answer will be ASO titer, ESR CRP at the acute phase reactant. Echo is very important, ECGS of course, to see associated carditis. Next, what is the treatment? Particularly for this choric moment. Haloperidol, okay. Anything else? Valproate people have used, yes. Very good. So what is the response, Lata? To control the chorea, drugs like valproate, as I say, carbamazepine, dopamine, receptor antagonists. Please, haloperidol, even we have used in the past, but nowadays people don't recommend it because better drugs are available. And very important point, please don't miss the penicillin prophylaxis. Even, rheumatic chorea does not require even the criteria for this Jones criteria. It does not require, and you are not going to get it. Chorea, synonym chorea itself is sufficient to say it's a rheumatic condition. And here, please don't miss to start this penicillin prophylaxis. That is very important. Next question. I think now we can go for one or two questions because gradually we have the time.
10:26. We can go for
Okay. A 10-year-old girl presented with, the OSCEs are many, so it is not going to end. The only thing Lata's word will make the end of our discussion. 10 years old presented with change handwriting, already we have written. Behavioral changes and intermittent abnormal twisting posture of limbs, rapid involuntary jerky dance-like movement again of 8 months. Her younger sibling died at the age of 4 years due to the jaundice and hepatic encephalopathy without any obvious reason. But the questions are going to be different, friends. So wait for some time. Probably diagnosis, yes, probable is Wilson. With neurological presentation. Wilson can present early age group with a hepatic manifestation. With the 8 to 10 years or beyond that, they very common is the neurological manifestation. And the next question is, what ophthalmic examination finding would be an important clue to the diagnosis? And it is going to be present, if I am not doing the mistake, more than 80% cases of neurological Wilson. Yes, KF ring, somebody will ask you what are the other features of even the on eye examination. Sunflower cataract, yes. But KF ring is a diagnostic. Next answer, Kaiser flexion ring. What is the mode of inheritance of this disease? Wilson. Yes, autosomal recessive. Can you click the answer, Lata? Next question. What is the gene implicated in this condition? This becomes the difficult answer. Next question. Yes, but still people are able to put, I will appreciate. ATP7B, somebody has put even the exactly answers. So good. It seems that you are well prepared for the exam. I will appreciate. Next. What biochemical test would you like to perform? That means which investigations? Yes. Ceruloplasmin. So many answers are there. Dr. Lata, can you click the answer? Serum ceruloplasmin, which is going to be low. 24 serine copper is going to be high. And even some people say you can go for the challenge test. The D-penicillamine and then see the urinary copper. Genetic testing will be the final. Good. Next question.
But sir, we are not seeing your slides anywhere.
Is it?
Yeah.
I'm able to see on my laptop.
Yes,
Lata,
sir. Yeah, I'm able to see.
Yes, it's
so,
visible.
I think we can ask some other students also if anybody is
Yes, it's
finding
visible,
difficulty.
visible.
Yes, sir.
Okay.
We are able to see, sir.
But in my screen, how can you see?
Then it's a not generalized problem, some localized problem. Yogesh bhai. You can check.
Okay, go ahead.
I think my laptop has created the problem. Similarly, probably yours.
No, sir. My laptop can't, I can. Sir, my laptop can't, I can.
What are the expected finding on MRI brain of this patient? I'm really happy. The panda sign. Very good. Lata, can you?
Yes, sir.
Yes, bilateral basal ganglia involvement. The presence of face of giant panda sign. Somebody said panda sign, but somebody said panda eye sign. I think good. Next, face of gender. What is the treatment? From one OSCE, even if you can say, from these questions, almost Wilson is discussed. Zinc penicillamine, D-penicillamine is the answer. Very important. But somebody had put the zinc also. Then the question, why zinc? Yes, chelation therapy with the D-penicillamine and copper restricted diet. Please don't forget it. Restriction of copper. And oral zinc supplementation. Why the zinc is required here? Why the zinc is required? Anybody can explain? Yes, somebody has put chelation. No, chelation is by the D-penicillamine. Reduce copper absorption to some extent, yes, because some book has mentioned, but still very specific answer. I will not say wrong answer, but the very specific. Zinc also retards the absorption of copper. Yes, it is there, but something else. Zinc is also chelated, very good. With the use of D-penicillamine, copper is chelated. But with the copper, zinc is also chelated. And if you don't supplement, there will be zinc deficiency to this patient. That is the reason why we go for the zinc supplementation. Very good. Next. Okay. I think, these are the things which people say even sometimes to ask the, even the, that you should go for counseling to the parents regarding the disease, regarding the treatment, and then you should know. Please, I think here I am not a specialist in the neurology, therefore I am not good in EG. These are the pictures from the books, but they are asking. And common conditions I have selected, which one I am also familiar. And they are EG, ECG in the exam, that always keeping the very common conditions. They will not put the uncommon conditions for the pediatric exam, maybe probably for neurologist. Here 10 years old boy was referred for gradual worsening school performance, behavior problems and cognitive decline over 6 months. He also has complaints of frequent falls and sudden jerks with injury marks over the forehead. Child also had seizures. EEG was performed by the pediatric neurologist and reported with some specific changes leading to the diagnosis. I think from the description, diagnosis may be clear, but the questions may be different. Probable diagnosis, yes. Not many students have put the diagnosis. So, Lata, can you click the answer? That is subacute sclerosing part encephalitis. But the next question, what specific past history may favor the diagnosis? Past history, and therefore history of measles, yes. Suppose no measles, anything else? One is the measles, okay? Not measles-like rashes. Past history of measles, and even the measles occasionally vaccine. Not so, not history of mumps. Mumps does not cause this SSP. It is measles only. And here, I think 1 into 10,000 or some is the incidence with the history of measles, and 1 into 1 lakh or so, even the measles vaccine. Okay, next question. What is the specific EEG changes? Answer should put the, I will say, answer was there on the chat box. So Lata, what is the answer? EEG changes? Very classically, periodic complexes. Next question. What is the confirmatory investigations? Which investigation? EEG is highly suggesting, you can say. But what is the confirmatory investigation? Anybody? CSF, but what CSF? Anti-measles IgG, yes, measles antibody. And please, measles antibody is CSF, not serum. Answer is, Lata, CSF anti-measles antibodies. And EEG changes. Very classically, you can say assessment. Next question. I think, should we keep it the last one?
Yes,
Lata?
sir. Yes, sir. It's already 22:30.
Because for me, probably I may continue, but I will have to keep in mind the timing also. A 10-month-old child present with afebrile encephalopathy. Please remember, afebrile encephalopathy for 2 days, followed by vomiting and running nose for a day. His development was normal. Child had frequent dystonia, which was observed on admission. MRI brain showed symmetrical basal ganglia and brainstem T2 hyperintensifies with diffusion destruction. MRIs gave an important etiological clue. And therefore, question is, what is probable diagnosis? Somebody has Canavan, somebody has mentioned Mela, Edem. So I think here I will get the multiple answers. Okay. JE, that is Japanese encephalitis. Pantothenate kinase associated degeneration. Very good. If somebody is knowing, I am not aware. Anyway, Lata, can you click the answer? It's a Leys disease. Yes, but the Dr. Rohit had put it just now, Leys disease. Good. I'll appreciate how he has come. If I'm really discussing in presence, I must have asked him the explanation that from which classical point you clinch this lace disease. You should go for lactate also. Good. Next question. What is the expected MRS finding? MRS, please remember, what is the MRS? It is MR, that is magnetic resonance spectrometry. What is an important clue on that? That MR spectroscopy, yes, very good. And what you are going to get it? Can you click the answer, Lata?
Yes, sir.
Double inverted lactate peak. Somebody put the lactate peak. I will appreciate. Good. What to be very frank, I am gathering the information. The students are well prepared and they are knowing really the good. Next question. What is the confirmatory test for Leigh disease? Leigh disease is again the degenerative disorder. Yes, NGS. What do you mean by the NGS? Can you put the full form? I may not be aware. MRI brain, okay. Yes, Lata, can you click the answer? Genetic testing. Yeah, I think therefore they mentioned this next generation sequencing. Okay, next. And what is the treatment? For Leigh disease, specific treatment is there. Treatment, yes. Now you can click it, no problem. It's some drugs. Here you have to go for carnitine. Thiamine is very specific for this. Somebody may ask the question. I think I have put even in the future we'll go for the other OSCEs. Then some of the neurological disorders are treated by specific vitamins. Somewhere pyridoxine, somewhere thiamine, somewhere even the B12, folic acid, some neurological conditions, and some even metabolic disorder, even biotin here. For dystonia, we can go for trihexyphenidyl, physiotherapy, stimulation. Okay, next. Okay.
Next question.
I think, should we stop? Okay, I think keep it the last now.
Yes, sir.
So this is last. A 2.5 years old male child born to third-degree consanguineous parents, presented with encephalopathy and seizures. His development was delayed. Perinatal period was normal. That means not birth asphyxia. Examination showed alopecia, seborrheic dermatitis. He lost his elder sibling at 7 months of age due to similar illness and refractory seizures. It's fantastic. Somebody has put the diagnosis. Investigation for negative. So, Lata, what are the questions? Diagnosis already people have put it. So, you can click the answer. It is biotinidase deficiency. Please remember for the practice point of view. I remember 2-3 patients I must have got referred by the dermatologist or somebody. Seborrheic dermatitis not responding with some neurological manifestations. Always think for the biotinidase deficiency, and it is very simply treatable condition. Don't miss it, and not the uncommon. Next question. What is the mode of inheritance? That you can click the answer. Autosomal recessive most of the times. Next question. What investigations should confirm? What investigations? Can you go to the answer, Lata?
Yes, sir.
Yes, biotinidase enzyme, genetic testing, even TMS. Next question. What is the treatment? Already, I think, obvious. Can you go for the answer? Biotin supplementation. 10 tablets is costing only probably 6 rupees. Very cheap, and effect is marvelous. Once you give it within 10 days, obvious improvement. Parents will be so happy. And I think not uncommon condition, which we should keep in mind. Okay. I think, is there any question to this condition, or should we stop here?
Yes, sir.
Is there any risk of recurrence of this during the next pregnancy? Already we have seen that the death was there. 25% in each pregnancy. Okay. So I think we'll end over here. Lata?
Should I stop sharing, sir?
Sorry?
Should I
Yes,
stop
yes,
sharing?
yes, you can stop sharing.
Okay, sir. Okay, sir.
I think in spite of the technical issues of my laptop and several other things, I tried even on this, my iPad and even the mobile, but ultimately we could manage. So we'll end over here.
Yes, sir.
So
Yes.
over to
Thank you,
you,
sir.
Dr.
Thank you, sir. Thank you very much.
Thank you, sir.
So
I hope
overall,
that I want the suggestion from senior pediatricians, teachers, that if you want some modifications, we can. But these are the common questions with the OSCEs, which I have observed for several years. Even not, I will say, for conducting exam. The OSCE questions are not available after this board, because national board is not releasing. And therefore, what I used to do, that I will attend all the questions, keep in mind, same day I will write down some of the points so that I can recollect later on, prepare the OSCE so that I can have the collection. And probably at present I have more than 750 or 800 OSCEs in my pen drive. So we can continue for longer time also when most of the conditions will be covered. And
Yes.
it is always, I will say, interactive, interesting. Not only I will say for exam, even the practice also. I'm sure that so many things are useful for our daily practice also. And it's a, I will say, not boring session. It's interesting with the interaction. We can enjoy. People don't feel even the bored, and they can even interact, respond with us. They also feel that yes, I was right. I could answer. I know this condition. And always it becomes, I will say, good for the students and when the practitioners also.
Yes.
So thank you very much. I end over here and hand over to Dr. Lata and the team.
Thank you, sir. Thank you, Yogesh sir, Sandeep sir, Jhankhana ma'am, always there till the last section. So it was really a tricky thing today, but sir
so
managed beautifully.
Lata, this is the commitment of the president, madam.
Yes, definitely, definitely.
And
She's
see,
always
our
there.
vice president, even though he is traveling,
Yeah.
he is from beginning. And thank you, Sandeep bhai, for this helping us today. So today we reached the 85 participants. This is the
Yeah.
maximum in the OSCE and the panel discussion.
Mhm.
So madam,
we are also always student when Baldev sir is taking
Teacher,
something.
yes.
yeah, but
Yes.
see, our learned teachers are also there. So many people are
To be
there.
very frank, Sandeep,
They
as you
can
have
join us.
mentioned, let me clarify from my side. Many people are asking me that why even you are doing so many things, even at this age or after retirement or so many. To be very frank, always I answer that there is one hidden interest for me, and that is to learning.
Yes, that is
Even
the
for my learning, that is I will say my interest. That while interacting, while preparing, and it is not, I will say, only for learning. Same thing is useful in the practice also.
Yes, sir.
So always I will say all of us should remain as a student, and it is interesting. And to be very frank, I am very happy that since last few years, our Gujarat team is very active in this type of the academic, I will say, organization, that different activities, either the quiz or the OSCE or the discussion, case discussion, the various, these are the modes for the learning. So to be very frank, it's always good for all of us. And we can give even something to the students also. They are also getting benefits. So
So,
that
sir, in the beginning, I told about we completed the 5 years today, means this week. We started on the Saturday and we are completing on the Thursday. So that is in 2021 started with the PG clinic on the Saturday and then Sunday. So Lata, also I learned today one more thing from the Zoom. I have a two screen. One is the meeting mode and the second is Lata's screen. So there is no technical problem in my computer, but I learned today. I have as a host, I have a two screen. Okay.
Actually, I tried Yogesh Bhai for 45 minutes. Even I called my computer person also, who is helping me. Even on the video, he also tried to guide me. it didn't materialize. Then just 15 minutes was there.
That was the, sir, the link problem. It was.
And then I asked Lata that you can project on your screen, and then I'll be able to discuss and we can manage.
Yes.
So, Lata, what we can do in the next session while we are joining, at that time we have to share the screen and check the issue, that what are the issue we can have in the during the presentation.
So actually, that time it was moving. I had tried. Then again, it stopped moving. So I don't know what happened in the between.
No,
All are the technical issues, and all of us may not be that expert. At least from my side, really, I am the very limited knowledge for this type of thing. But gradually we are learning because we are using daily.
But every time we are using same link, na sir?
No, Sandeep. No, Sandeep. Today is some issue.
There was some.
I think last time it was informed me that the same link is there.
Yes, sir. Yes,
Yes,
sir.
yes, yes.
Yes, that is.
The
Anyway,
glitch was there this time. No, it's okay.
ultimately
We'll manage it.
do. Thank
Actually,
you
it
very
is.
much, all of you, and good night.
Yeah,
Good night.
we
Good
will
night.
discuss in the
Thank you
group,
very
sir.
much, sir.
Good
Thank
night.
you.
Good night.
Good night,
Good night
everyone.
to everybody.
Good
Jhankhana
night.
madam, Yogesh bhai, Lata madam.
Good night.
Good night. Good night, everyone. Good night.
સંદીપ ભાઈ શેર કરતા રહો નિયોનેટલ પાઠશાલા ઈ ગુરુ પાઠશાલા બીજા કરે કે ન કરે તમે હું કરશું તો બી 50-100 તો થઈ જશે.
તમે મને ખાલી રિમાઇન્ડ કરાવજો થઈ જશે.
ના આજે કર્યું હતું સવારે કાલે ફોન કર્યો તો આજે બી હું કરાવીશ. ખાલી લતાની મારી ડ્યુટી નથી બાપા ઘણા બધા લોકો છે.
ના.
મેડમ થાકી ગયા હવે બહુ થયા.
ના એટલે ખાલી કહી દેજો.
So you are the backbone, sir. You are backbone, sir. Please.
Okay.
Okay.
Good night, everyone.
Good night to everyone.
That was a nice session.
Good night.